Hi, my name is Omar Lopez. I'm from Texas A&M University, Central Texas. I'm going to talk to you about borderline personality disorder today, or BPD. So what exactly is BPD? Well, first of all, it's a personality disorder. So personality disorders, by definition, have to have some kind of pervasive pattern of behavior. In borderline, one of the most pervasive patterns that we see is instability. Instability in things like relationships, things like self-image, and sometimes affect. In borderline personality disorder, one of the major symptoms is feelings of abandonment. That's one of the major things, the driving force behind borderline personality disorder. And one of the other criteria that we use is self-damaging impulsivity. So being impulsive and doing things that can be damaging to you. This can include things like excess spending, sexual promiscuity, driving quickly, things like this. One of the things when we talk about self-damaging behavior, we're not talking about either non-suicidal self-injury or suicide attempts. So whenever we talk about some of these impulsivity things that can be damaging, they can be damaging, but the intention isn't that. With self-mutilation or non-suicidal self-injury, the intent is to cause physical harm. Usually it's something like cutting, maybe burning cigarettes. And outside of that, this is also kind of the same criteria outside of that self-mutilation. With this particular personality disorder, there's a lot of threats or attempts to commit suicide, and usually this is recurrent. So, especially in young adults, we see this a lot, and we'll see that as they get older, we'll see this start to wane off. But early on, adolescents, young adults, we'll see multiple suicide attempts. This population is has one of the highest suicide rates. And one of the things that's really just out there for borderline personality is chronic feelings of emptiness. So one of the things that they'll talk about is they're just kind of there. Sometimes they'll describe it as numb. They don't really have a whole lot of, affect. Their affect can be very flat. One thing with borderline at some level, right? I've never seen this, but because of that impulsivity, it can get very intense anger. So, what does that anger look like? It can be some kind of simple issue might come up, and the anger that they display will be out of proportion for that response. So you'll see that sometimes we can see this through like recurrent physical fights, right? They'll fight all the time as they're adolescents in school, or they'll get in trouble with the law, right? They'll go out and they're constantly in jail for fighting or for some kind of physical altercations. And sometimes they'll just tell you, I'm always angry. It's a thing. Less likely, less often, what we'll see is some of these like stress-related paranoid ideation, severe dissociative symptoms. That's a little bit less likely, but it does happen. So that's something that we can look towards and be mindful of. So what do we know about this population? Well, starting with, it seems to affect somewhere between 1.5 and 6% of the population. One of the reasons why that number is so large, that's kind of a big gap, right? 1.5 to 6 seems like it's kind of big. It's because sometimes we avoid diagnosing adolescents, and sometimes people just don't believe that they have an issue, and they're not able to get the help they need. And sometimes They just don't have access. I knew somebody who lived in a pretty decent sized area, but it was difficult for her to get the treatment that the counselors that she was seeing was recommending. So she just wasn't able to see it. Most diagnoses are for women or for females. Don't know why, but the majority of them are for females. A lot of our assessments are normed off of females. A lot of our treatments are normed off of females because this is just more prevalent in females. So the point of this particular research project was looking at adolescents, in particular minority female adolescents. One of the things that we found was there's just not a lot of information out there for minorities, or in this case, African American adolescents. There's just not a lot of information out there for adolescents, period. There's a lot of reasons for that. One of the reasons that we don't have a lot of information on there is just people haven't tried to conduct the research. It's just not out there. There's just not a whole lot of research kind of hodgepodge out there. The other reason is mental health still has a strong stigma, especially with something like BPD. BPD is a personality disorder, so it's up there with things like, bipolar disorder, antisocial. So when people hear mental health terminology, they don't want to be labeled. And even to this day, there are people out there who will avoid getting diagnoses for adolescents, especially adolescents, because they don't want them to be labeled. Another thing is that professionals sometimes are reluctant to diagnose BPD in adolescents. One of the reasons why is some of this stuff may seem like normal adolescent behavior. Well, what do we mean by that? Well, some of it's like the impulsivity, right? Promiscuity. That can be seen as potentially kind of normative for maybe older adolescents, young adults. One of the examples in your DSM-5 is fast driving. Driving fast, looking for whatever high that is, might be kind of normative depending on the culture, even within the United States. So seeing that as potentially just kind of normal adolescent or young adult behavior may push people away from assigning you to diagnosis. What we do know, one of the things that we do know about BPD is that people with BPD have a high chance of being comorbid with other things, one of them being substance abuse. If you have BPD, you're more likely to abuse substances like alcohol and methamphetamines. One of the hypotheses for why this is I know somebody who had this who said, I just want to feel something. One of the reasons for things like self-mutilation, they just want to feel something. And this may help them with that, or they may feel like this helps them with that. So it could be a form of self-medication. They may feel like this is something that helps them, and it helps them get away from sometimes anxiety or depression that they're going to go through. One of the things that's interesting was the severity of borderline personality disorder actually predicted the prevalence of substance abuse by one of these studies. So the more severe the borderline personality disorder is, the more likely it is that you'll be using some substance, alcohol, marijuana, and methamphetamines. Another thing that we see with BPD is a skewed view of sexuality, especially in adolescents. So what they'll say is they'll normalize risky sexual behavior more than their peers will. So if you ask something about when they lost their virginity, it's more acceptable to them. Any kind of promiscuity, more acceptable to them, because they believe that their peers are doing it at a greater rate than they really are. But what they have found is that they don't engage in more sexually risky behavior than their peers on average. There's still that impulsivity that can go along with that. but a lot of that does other stuff too, right? Spending, fast cars. Um, there's other stuff with that. And sex is part of it. Binge eating is one of those impulsive behaviors also. So in general, they don't engage in more sexually risky behavior, but they do see it as more normal. They have been able to see that they have earlier sexual debut, so they started sex early. One of the things that we know about BPD is that there's a higher prevalence of people with BPD who experience some kind of sexual assault or sexual abuse. So that may play a role in that. Um, Not sure yet. And another interesting thing about sexuality with this population is they have less self-efficacy to refuse sex. So what that means is, specifically females don't believe that they're allowed to say no when they're approached sexually. So that's a potential issue that clinicians should be looking at, especially when we're talking about adolescents. So this is something that I mentioned a little bit earlier. We're talking about self-injury. One of the things is non-suicidal self-injury is one of the earliest indications of BPD. This isn't suicide. This is them hurting themselves. And again, I knew someone who said, I just want to feel something. Sometimes it's really that simple. Most common are cutting and burning. They'll cut themselves or they'll burn themselves. Sometimes they'll go to the emergency room because they made a mistake. They weren't trying to kill themselves, but they may be cut too deep. And this is, again, one of those things that some clinicians may see as normative for adolescents in certain subcultures. So it doesn't become a BPD NSSI thing until it's done repeatedly. It's a habit. It's not in the context of some kind of social cue. That's important to understand. And this self-injury is more common with BPD, and BPD is more common in people who engage in NSSI and attempt suicide more often. One of the things that we've seen in people with BPD is about 30% of their NSSI began during childhood, and about 30% began in adolescence. So the majority of that kind of self-injury actually began really early. So this should be indications to us in adolescence or even childhood that this is a potential BPD case in the future. And this was the strongest correlate to female adolescents with BPD. So female adolescents that engaged in SSI, that was a strong sign that they either did have or would develop BPD. So now we're going to talk about the assessments. There's a couple of different assessments. There's a lot of different assessments. Some of these assessments are actually subgroups. So the MSI BPD, the McLean screening instrument for Borderline is actually a subgroup to the McLean screening instrument. It's a short form. It's quick. It's only 10 items. It measures a couple of different things. It starts off with social relationships. It measures self-image, and it measures self-harming behavior. There are yes or no responses. Real quick, yes or no. Anything above a score of 7, I remember there's 10 items, so anything above a score of 7 is a cutoff for likely BPD diagnosis. And it's got moderate validity when compared to semi-structured clinical interview. And when they first normed this, the population they used was about 64% female. So again, really strong correlations with females. Sorry about that. The next one we're going to do is a self-harm inventory. Now, self-harm inventory, what it does is it actually is very specific. It actually only measures a single component of BPD, which is self-harm. It's normed off the clinical interview for BPD right out of the DSM. Normed off of that. It's 22 items. Just like the MSI BPD, They're yes, no responses. Yes, yes for affirmative, no for negative. And this also has a cutoff score of 7. Now, because it's such a focused inventory, the cutoff score is going to be lower. It's still 7. They're both 7, but one of them has 22 items. This one, the other one has 10 items. One of the interesting things is it's been compared to the PDQ-4, and it's found to be valid when compared to that. Even though it measures a single aspect of BPD. So that's important. So it can be used as a proxy for the PDQ. The next one is a clinical interview for borderline personality. This is the most used measure for this. The most used measure for borderline. This is a semi-structured interview, right out of the DSM, and we go down the line. That's basically what it is. The most widely used assessment tool. This is what other inventory aren't going off of. This is what they're compared to. You do a clinical interview for borderline personality disorder. You do the other thing, and we find out how they correlate. This is the gold standard, and my personal preference. This is what everything else compared to. Yeah. The last one we're going to find is a little bit interesting. The borderline personality feature scale for children. It originally started with 24 questions. It's down to 11. It's on a Likert scale. The norm off of that was about 64% female as well. And it has pretty good moderate convergence to the PDQ for BPD. One of the interesting things about this is it actually does not assess for self-harm. It does not assess for self-harm. So what does that mean? Well, what that means is we may be able to assess for BPD without getting into confronting some of those undesirable behaviors and allowing them to be more comfortable with us and building greater rapport while going towards that without them pulling back. Because one of the hardest things with borderline is actually getting them to come in to sessions. So this may allow us to be able to do that. Now we're going to look at a couple of treatment options. The first one is essentially the gold standard, which is dialectical behavioral therapy. It was developed specifically to address the challenges of BPD by a great researcher called Marshall Linehan. It focuses on dealing with the emotional dysregulation of BPD. It has 4 components, and it wasn't developed for adolescents, but it's been effective in adolescents. And this is a treatment option that all other newer treatment options are trying to be compared to. This is what they can compare themselves to. The last thing is, or the second thing is CAMS, Collaborative Assessment and Management of Suicidality. This is a short-term intervention. This is, for one thing, is to manage suicidality. Is to manage and reduce suicidal symptoms. That's it. The first thing they do is they try and foster a strong therapeutic alliance. That's their main focus. And it's about continuous risk assessment, continuous treatment planning, and continuous interventions specific to suicide. It's been used effectively with adolescents. And it's been compared once again to DBT, and it's been shown to be effective compared to DBT. Again, short, simply for one thing. Prevent suicidality, get them back in safety. The last thing is systems training for emotional predictability and problem solving. So the STEPS program. The thing to know about the STEPS program is the STEPS program is a supplemental intervention. So we use the STEPS program only in addition to other interventions. Sometimes we send clients to groups or to maybe equine therapy or art therapy, something very specific. That's what this is. It's a supplement to any other intervention that you have. It's been shown to be effective with the adolescent population. Again, it was shown to be effective in an adolescent population that was 81% female. and its biggest strength is it reduces chronic feelings of emptiness, impulsiveness, and it increases overall function with people with BPD. One of the things with stuff with BPD is one of those things that's really difficult to deal with. But one of the positives is once people with BPD get past their early 30s, maybe 40s, we see some of these suicidal effects of it start to wane. So there's definitely light at the end of the tunnel. So what we need to do as clinicians is focus on getting those clients into a good place and make sure that we can get them moving forward and just push through that. The biggest challenges that we have are young adults and adolescents through this population.